不会就直接开始，就直接开始 ，OK。那我要按什么吗？我这边按什么？
不用，我已经帮你看好。
所以它是现在已经有声音了。OK。
有简报有声音，很清楚。
那我就直接开始哦。
还蛮好的，所以你就
好，
谢谢医师。可以。
OK。好。Okay. Good morning, everyone. I'm Dr. Yin Zhimin, and it's my pleasure to have this lecture to all of your student in the International Medical University of Malaysia. Today I'm going to talk about the updates on the surgical treatment of the pancreatic disease. Mostly we'll focus on pancreatic cancer because this is a very important and with a high mortality and morbidity disease. And today we'll talk about the update surgical technique and how we can use this technique to treat this very difficult disease. Okay, and this is my CV. I'm now attending surgeon of liver transplantation team and pancreatic surgery in Kaohsiung Chang'an Memorial Hospital. I was training in Kaohsiung Chang'an as a residency. Before, I also participated in the Taiwan Medical Mission in Eswatini. And in 2019, I went to Regin Hospital for the robotic surgery fellowship in their pancreatic cancer center. So that's my CV. Today we'll talk about start from the pancreatic cancer epidemiologies and its clinical manifestation and how we diagnose this cancer, and our focus will be how we provide surgical treatment for this very difficult disease, including how we do the preoperative planning, what is the accurate, what is the important anatomy of this pancreatic disease, and what type of surgery we should perform for the patient, and what kind of complication we might face during this pancreatic surgery. And finally, we'll talk about a little bit about the surgical progress currently in pancreatic surgery. Okay, well, we know some celebrity already passed away due to the pancreatic cancer, including Pavarotti, and an Italian opera singer, and also a famous co-founder of Apple company, Steve Jobs. Those two people, they have power, and they have this disease, and they receive a very advanced medical treatment, but still unable to beat this very difficult cancer. So this disease is not only the can deal with surgery only or some simple medication or chemotherapy only. It needs a lot of knowledge and technique and medication and combined with teamwork to treat this cancer. This is the cancer-related mortality in Taiwan. It's reported in 2019. And we can see it's already the big 10 cost of the cancer-related mortality, and there are more than 2,000 people died because of this disease in 2019. And also, I searched some statistical data from Malaysia, and I'm very surprised about the survival in Malaysia, which is very different from Taiwan. And because when I search for the relative survival of the stage 1 pancreatic cancer, we can see this cancer is the very difficult to treat, even if it's a stage 1 cancer. You can see the 5-year survival only less than 20% if you have the pancreatic cancer in Malaysia. On the other hand, what made me surprised is that when the stage 2 pancreatic cancer, in Malaysia have a better survival in the 5-year related survival, which is very different from the data in Taiwan. And when we see this is the data from Kaohsiung and Linkou Changgen is the biggest hospital system in Taiwan. And we can see the 5-year survival of stage 1 pancreatic cancer can reach around 80%. However, when this cancer progresses to stage 2 or further, the survival will drop down very quickly. The 1-year survival in our hospital is less than 50%, and in Linkou Changgen, the biggest hospital in Taiwan, and only 61% in the first year, the 1-year survival. And when you see the 5-year survival, both of our hospital were less than 20%. And if you have stage 3 or stage 4 cancer, the 1-year survival is even worse, less than 40%. So this is the data more compatible with the world data, the data in United States or in Europe, but it's very different from the data in Malaysia, which made me very interesting about what happened in stage 1 cancer in Malaysia, because sometimes most of the stage 1 pancreatic cancer is able to treat with the upfront surgery, which means this is the data, Taiwan National Registration data in 2017. The initial treatment of the pancreatic cancer with surgery is about 27%. And this group of patients, mostly they are stage 1 patient, which means if you have a stage 2 or more advanced pancreatic cancer, most of these patients will be treated with chemotherapy or radiotherapy as an initial treatment. Or if you have a more advanced cancer, you can only receive a palliative treatment only. So I'm wondering that the relatively low survival of the stage 1 cancer in Malaysia might related with the surgical treatment, maybe some surgical treatment difference from the other country. So maybe today my talk about the surgical treatment will have some benefits or some idea we can share our experience about the surgery treatment, what's the difference and what is the new advanced progress in this area to you. Okay. So why is the pancreatic cancer have such a low survival rate? The main reason of this difficult treatment and the diagnosis is because pancreas is a retroperitoneal organ, which means it's in a very deep part of our body. When we open the abdomen, or we use some abdominal echo to do the screening, it's very difficult to screen the whole pancreas directly. And mostly in the pancreas, the tumor will not cause any symptoms. Or once you feel pain, or you feel you discover the yellowish skin, which is the sign of a symptom of obstructive jaundice. Normally, this tumor is larger, is big enough to reach like stage 2 or stage 3 cancer. And there's no very good specific tumor marker. We know the tumor marker of the pancreatic cancer is CA99, but it's not very specific to its malignancy disease. So if you want to do the screening, you couldn't find a very accurate tumor marker, and it's also very difficult to use some simple screening tool like physical examination or the ultrasound to detect this tumor. So what is the possible early symptom of pancreatic cancer? Most of the patient will start from jaundice, because once this tumor obstructed the periampular vata area, it might cause the obstruction of the biojuice, so it causes the obstructive jaundice. And if the tumor becomes larger, it will compress the neurovascular bundle around the pancreas, and then will cause the abdominal pain. And once this tumor is big enough to compress the duodenum, the GI tract, a patient will have nausea and vomiting and cause the body weight loss. And some new study had give us an idea. Once you have a sudden onset hyperglycemia status or new onset of diabetes status without any family history and without any other medical reason, there might be a risk of newly diagnosed pancreatic tumor. So these are some early symptoms we should be aware of. And we look at the guideline from NCCN guideline, and we can find that for the diagnosis of the pancreatic cancer, the standard gold standard of the diagnosis, you need to do the abdominal CT or do the MRI for the diagnosis. So it's very difficult to use these two image study to do the screening as a screening tool, because it's very expensive in our medical system. So that's also the reason why pancreatic cancer is very difficult to detect. And when we look back at the tumor staging of the pancreatic cancer, you can find that once the cancer is larger, bigger than 2 centimeters in the greatest dimension, this cancer will jump to the stage 2, which is the T2 classification. And once it's larger than 4 centimeters, and you will become the T3, which might lead to the stage 3 in our classification. And that means once you want to early detect and early treatment for the stage 1 pancreatic cancer, then you need to detect this tumor, which is less than 2 centimeters, and start your treatment earlier. But it's very difficult because, as we just mentioned, it's a retroperitonean, organ, and it's difficult to use the screening, some easily screening tool to do the early detection. So that's why the survival will always, until now, the survival is always very low in this disease, because it's very difficult to do the early detection to detect the tumor less than 2 centimeters. Even if you use the abdominal CT or the MRI to do the detection, it's very difficult to observe or find this very small tumor. So this is also the limitation of the transabdominal and CT guide biopsy, because once you detect this tumor, you cannot do the definite diagnosis because you need to do the biopsy of the tumor. But this pancreas and the pancreas tumor is in the retroperitoneal area, and you can see it's related to many major vessels, including SMA and SMV, and also the splenic artery and vein. So, and if you want to do the biopsy, you need to penetrate the stomach or penetrate the duodenum or from the other side to reach this area. So it's both also difficult to detect and difficult to perform a safely biopsy for the early stage of the pancreatic tumor. So, but it's very important to have the preoperative diagnosis, which means the biopsy before we have a definite treatment, like a surgery or the chemotherapy, because we need to do the differential diagnosis about whether this cancer is a malignancy or not, or it's just some like neuroendocrine tumor or some cystic lesion only, cystic neoplasm only, and we need to do the precise preoperative staging. And also in some condition, we would like to do the neoadjuvant treatment first, which means if we have the preoperative diagnosis, we can provide chemotherapy first for the patient, then following by surgery, which can make this disease have better prognosis. And also the chance, preoperative diagnosis can give us a chance to perform minimal invasive surgery. So currently we like to do a new technique for the diagnosis, which we call the US biopsy. It's a endoscope ultrasound biopsy. We use this, we combine the ultrasound and the endoscope to detect the pancreatic cancer and perform the biopsy with this tool, and we can do the biopsy through the entrance area or the duodenum area. And this is a tool we can have a high sensitivity for the small pancreatic cancer, even if the cancer is less than 2 centimeters. And we can do the biopsy along with the EUS, so it can perform the diagnosis and the biopsy together. And another technique is if US biopsy is still difficult to detect the tumor, the surgeon can do the laparoscopic intraoperative biopsy. The same we can do a minimal invasive way. We have some small trocar and use the ultrasound, and we can divide the omentum to enter the retroperitoneal lesser sac area. Then we perform biopsy. There are some benefit of laparoscopic biopsy, like the accurate staging, and we can repeatedly this biopsy, and until we have accurate the diagnosis of the cancer. And also we can, with the laparoscopic approach, we can avoid the complication of the biopsy, including like bleeding by the biopsy needle or some bowel injury during the operation. And with this way, we can combine the other neoadjuvant or palliative procedure. For example, some in the late stage of the cancer, we can do a biopsy, then we can do like the bypass surgery for the patient, or the feeding stomy, jejunal stomy, like some feeding procedure, palliative procedure for the patient. So it's a very, the laparoscopic biopsy might have those benefits. And after all the accurate diagnosis, we should start to prepare our the surgery. If the patient is suitable and their condition is able to receive this surgery, we should start to prepare many things. For example, this is if you want to do a pancreatic surgery, it would be a very complicated surgery. So before the surgery, we need to do the survey of the cardiovascular status of the patient, because during the surgery, we may have some blood loss. The patient's body volume status will vary a lot, and it will cause a lot of pressure to our cardiovascular system. Another thing we should always keep in mind that the pancreatic cancer might also combine with other organ invasion. Mostly it's colorectal system, like a T colon, or sometimes you will related to a long segment of the major vessel invasion. So sometimes we need to do the surgery together with a colorectal surgeon or even a cardiovascular surgeon. And in pancreatic cancer, if you have obstructive jaundice, you might also encounter with the biliary obstruction problem. And some of the biliary obstruction problem will cause infection, including the biliary tract infection or intraabdominal infection. So before the major surgery, we would like to control the infection first and do the accurate biliary drain for the patient. Some of the patient, they already suffer from body weight loss and malnutrition due to the cancer compression. So preoperatively, nutrition support for the patient is also very important. For example, if the patient had decrease, their body weight decreased very quickly in the past few months, and the albumin status is very low, we'll give some partial nutrition or total nutrition for the patient. And finally, we have to do a very careful and precise family meeting and patient indication before the surgery to let them understand what kind of surgery they're going to face and what kind of complication and survival they might face to encounter when they encounter this very difficult disease. And before prepare the radical surgery, we also need to understand the critical anatomy of this pancreatic cancer. So later I'll show you some video about like the blood supply of the pancreas and how this blood supply will related to our surgery, and what is different if the tumor location different in the different area of the pancreas, and what's its relationship with the major vessels, and you will cause the different type of surgical procedure, and different surgical procedure and the different anatomy will we need to understand that to achieve the tumor clearance in our surgery. Okay, I found in the internet, in YouTube, I found this YouTube anatomy knowledge provide a very precisely blood supply anatomy of the organ. So I recommend that if you want to do the preview or the review of any anatomy analogy, you can always check this website, and it's very clear and simple way to understand the whole blood supply, the artery anatomy of the pancreas.
Today we will discuss about the blood supply to the pancreas. The blood supply to the pancreas is relatively profuse. It is derived largely from the celiac trunk, but also in part from the superior mesenteric artery. Now, let's put down these arterial structures. The celiac trunk arising from the abdominal aorta, just inferior to the hiatus of the diaphragm, splits into 3 branches: left gastric artery, common hepatic artery, and the splenic artery. The splenic artery, it has 3 parts related to the body and tail of the pancreas. The suprapancreatic part, located superior to the pancreas, the pancreatic part, located just posterior to the superior margin of the pancreas, and the prepancreatic part, located anterior to the tail of the pancreas. The splenic artery terminates by dividing on reaching the hilum of the spleen into a superior and an inferior trunk. The superior mesenteric artery arises from the abdominal aorta at the level of L1 vertebra and is directed anteriorly, inferiorly, and to the right, passing anterior to the uncinate process of the head of the pancreas and the third part of the duodenum. We are now in a position to indicate the pancreatic arteries, and we will start with the blood supply to the head of the pancreas. The common hepatic artery bifurcates into hepatic artery proper and the gastroduodenal artery. From the gastroduodenal artery, we have anterior and posterior superior pancreaticoduodenal arteries. From the superior mesenteric artery are arising the anterior and posterior inferior pancreaticoduodenal arteries. Those arteries will anastomose along the concavity of the duodenum to form the anterior and posterior pancreaticoduodenal arcades. These arcades give branches to both the duodenum and the head of the pancreas, and typically anastomose with other pancreatic branches. The blood supply to the body and tail of the pancreas is arising mainly from the splenic artery. First to indicate is the dorsal pancreatic artery, which originates from the splenic artery close to its origin from the celiac trunk. This artery, it typically passes downward, dorsal to the neck or body of the pancreas, to enter the pancreas and dividing into right and left branches. The right branch supplies parts of the head of the pancreas, and it can anastomose with pancreaticoduodenal arcades. The left branch of the dorsal pancreatic artery becomes continuous with the transverse pancreatic artery, which is also called the inferior pancreatic artery. The inferior pancreatic artery is a large artery that runs along the inferior border of the pancreas, and it's anastomosed with other branches from the splenic artery. In addition to the dorsal pancreatic artery, the splenic artery usually give rise to from 2 to 10 other branches to the pancreas. Most of them are small, but one of them, entering at about the junction of the middle and tail end thirds of the gland, is frequently larger than the others. It is the great pancreatic artery, or arteria pancreatica magna. This artery supplies a nutrient to the main pancreatic duct. The last artery to be indicated is the artery to the tail of pancreas, or the caudal pancreatic artery. This artery usually originates at the level of the hilum of spleen, from the inferior trunk of the splenic artery. It supplies the tail of the pancreas and anastomose with the inferior pancreatic artery.
Okay, so we can have a more clear concept of the whole blood supply of the pancreas. So it's very different of the blood supply of the pancreas tail and the pancreas head and neck. So when the tumor location different and in a different area, we might face a different difficulty when we want to resect this tumor. For example, if the tumor located in the tail and the very tail of the pancreas, normally it will invasion of the pancreatic tail and the splenic artery together. So it's very normally when the pancreatic tumor is located in the tail, it's very difficult to preserve the spleen together because the blood supply of the spleen will also be sacrificed during the surgery. On the other hand, when the pancreatic tumor is located in the body or even the neck of the pancreas, we might consider some situation that this pancreatic tumor might invasion the major vessel, something like the celiac trunk or aorta, or even the left gastric artery. And when this condition happen, sometimes we need to resect the celiac trunk, the whole celiac trunk together. This is a very complicated procedure called the celiac axis resection. We'll introduce this later. And also the splenic artery together, so the spleen cannot be preserved as well. Sometimes when the tumor is too large and invasion too many major vessels, this surgery cannot be performed as an initial treatment. And sometimes the reconstruction might be needed if invasion of the proximal side of the hepatic or the distal side of the hepatic artery. On the other hand, if the pancreatic tumor is located in the head of the pancreatic cancer, the pancreas, we need to perform the resection not only the pancreas only, because the blood supply of the duodenum might also be invaded by pancreatic cancer. So we will perform a typical procedure called Pancreatoduodenectomy. If the pancreatic cancer is located in the original process, we need to be very careful about the relationship of the pancreatic cancer and SMA, because SMA is the vessel we cannot sacrifice, because it's not only has the branch of the pancreas, it also have a lot of branch to the small intestine and the colon. So if we sacrifice this major vessel from the very root area, we might cause a large area of the ischemia of the small bowel and colon. So the relationship between the pancreatic cancer and SMA is very important during our surgery, and sometimes the reconstruction of this artery might be needed. Another thing is if the cancer is very big and the invasion of the pancreatic head, and it might also the same. We need to perform a pancreatoduodenectomy, and also to be careful about its relationship between SMA and major celiac artery, because major hepatic artery. If these two are invasion, sometimes the surgical treatment is not suitable for the initial treatment. And the most complicated status is if the pancreatic cancer is in the neck and body and of the pancreas, and in both have very close to SMA and celiac trunk and splenic artery. In this area, if we cannot successfully dissect this pancreatic cancer from these few major blood supply, the surgery cannot be go on. So, but if we can do this, and sometimes we need to perform the total pancreatectomy because most of the major vessel around the pancreas will be resected. And beside the artery supply, we also need to consider the drainage of the pancreas, which is the venous system. If the cancer is located in the tail or body of the pancreas, sometimes it will invade the splenic vein. So if we resect the splenic vein, will cause the congestion of the spleen. So sometimes if it has a major invasion of this vessel, we will do the splenectomy together with the pancreatectomy. And if the cancer is located in the neck and the pancreas head area or the Usina process area, sometimes the SMV will be invaded, and SMV is another very major vessel. We need to reconstruct it because once the SMV is not reconstructed or resected, it will cause the very quick congestion of the GI system, and the long-term congestion of the GI system, the sudden congestion of the GI system will cause also the large area of the ischemia of the small bowel and the colon. So it's a very complicated surgery, and you always need to be aware of the major vessel, and always keep in mind that the pancreatic cancer always need to, or you have to prepare for the major vascular resection. So it's very different from the other GI or HCC or early GI cancer or other cancer. Pancreatic cancer, its resectability status will be have a very close relationship with their status to the artery and venous, major artery and vein in this area. So when we say this pancreatic cancer is resectable, that means the cancer is not related to artery invasion, and it has only less than 180-degree contact with the major vein. That means we can do the repair or reconstruction very easily. Then we'll say this cancer is resectable. However, once this cancer had invaded the SMA or some variant artery anatomy, or the pancreatic cancer had contact with the celiac trunk, or this cancer had invaded the tumor, the tumor had invaded major vein like SMV more than 180% and this cancer will call it a borderline resectable, which means technically we can do the surgery, but it would not cause the survival benefit to the patient. Another thing is if this cancer is too big and invade the SMA or the celiac trunk more than 180%, or it's unreconstructable SMB or portal vein invasion, will classify this cancer to a locally advanced tumor. And normally this kind of cancer is better to do the neoadjuvant treatment first before we perform the major surgery. So the different status, different location, and different vascular status will lead to different type of pancreatic surgery. So normally in the head and Usina process cancer, we'll perform Pancreatoduodenectomy, as we just mentioned. And in the tail, the cancers, we need to perform a distal pancreatectomy with a splenectomy. And sometimes in the body, neck, cancer with a large area of blood supply invasion, we need to perform total pancreatectomy to achieve the cancer clearance status. Okay, so now we will start to introduce different kind of surgery. First, we'll introduce the Pancreatoduodenectomy. It's called also renamed as the Mountain Everest of the surgery, which means it's a very difficult and complicated surgery in the hepatobiliary surgery area. And it has two major parts of the surgery. One is the resection part, and the other part is the reconstruction part. Because of the blood supply, as we just mentioned, so we cannot resect the tumor only or the pancreas only. We need to resect the area of the pancreas head and its associated blood supply. So normally we need to do the pancreas resection and duodenectomy resection, okay? And if some surgeon will also perform the partial resection of the stomach, which is the gastrectomy or the enterotomy, and also the distal common bile duct and as well as the gallbladder will be resected together. Once the tumor is resected, then we need to do the reconstruction to make the patient have the normal GI function. And so we need to do the reconstruction both from the pancreas to jejunum and the bile duct to jejunum and also the gastrojejunum. So at least we need to make a 3 reconstruction in this procedure. And this is the video from the Mayo Clinic. We can have a very short video and the concept of the whole Whipple procedure. Whipple procedure is another name of pancreatoduodenectomy without pylori serine preserving. That means we have the enterotomy or gastrectomy in this procedure.
As we discussed, the Whipple procedure or pancreaticoduodenectomy, it's a very complex procedure. And that is because we need to take the head of the pancreas out. And the head of the pancreas has a very intrinsic relation with the intestine, the first part that we call duodenum, as well as with the bile duct. The bile duct is really a pipe system that brings the bile that's produced on the liver into the intestine. Now, commonly, a tumor located on the head of the pancreas will obstruct this pipe system or bile duct. And when an obstruction of the bile duct occurs, the bile gets backed up into the liver and reabsorbing the blood. And therefore, you develop jaundice, what is the yellow color of the skin. And at the same time, the stool color can become clay color because now the bile, that's the one that's responsible for the color of the stool, does not get into the intestine. Therefore, the stool again turns white. Now, besides taking the head of the pancreas, the intestine, and this portion of the bile duct, we need to take the gallbladder out. The reason for taking the gallbladder out is because the duodenum produces some hormones that help the gallbladder to function. Once we take the duodenum out, those hormones are not present and therefore the gallbladder doesn't function normally. At the same time, taking all of this out may impair the blood supply of the gallbladder, and therefore the gallbladder again has the risk of not receiving adequate blood supply and ill. The gallbladder is taken out at the same time of the surgery and really doesn't have any more consequences on the patient that all the rest I would have taken out. The reconstruction is done by putting all of this back together. If we divided the pancreas here, we call this A, and we divided the bile duct, and we call B, and we divided the intestine, and we call C. If we take all of this out, we're going to end with this situation. The intestine is called C, The pancreas is called A and the bile duct is B. We took this whole center part. We also divided the stomach past the area of the valve of the stomach at the first portion of the duodenum, and here we call D. This is usually helpful to be able to preserve the whole stomach. In some cases, we cannot do that because of the location of the tumor, and we need to take a part of the stomach along with the rest of the specimen. But in the majority of the patients, we're able to preserve the whole stomach. How do we reconstruct that? The intestine is the part that's movable. Therefore, we flip the intestine to approximate it to the pancreas and the bile duct. In this other drawing, we have flipped the intestine, the end that we had called C now is located here. We connect it to the pancreas, and therefore the pancreatic juices are emptied back into the intestine again. The bile duct is reconnected to the intestine a little further down the stream, and again now bile is able to empty back into the intestine. Further down the stream, we reconnect now the stomach to the intestine, and that is how food gets back into the alimentary system. Then the end result is, one more time, the food goes into the stomach, back into the intestine, pancreatic juice and bile get into the intestine here, and all get together, and you go back to have a normal absorption.
Okay, I hope you all are listening this lecture well and understand how this procedure goes on. Okay, so on the other hand, once this pancreatic tumor is located in the neck or the body or even the tail of the pancreas, we'll perform the distal pancreatectomy and splenectomy, which means, as we just mentioned, we need to resect the splenic artery and also the splenic vein. Then we resect the pancreas together with the spleen. So it's also sometimes we'll face some difficult when this tumor is too big and invasion the celiac trunk, and we cannot directly remove that without cutting the celiac trunk. And also before this procedure, we need to put the stomach up first, then to provide this procedure and blood vessel control. So also there's the video. It's a video when I doing the fellowship in Beijing Hospital. They perform a robotic distal pancreatectomy. Okay, so firstly, we need to divide the omentum to open the enter the lesser sac, divide the omentum and separate the stomach and the colon. Then we can see the pancreas and the tumor inside the pancreas. Then we need to dissect below the pancreas first to achieve those major vessels. So this is the tumor. Okay, we carefully hold the pancreas and the tumor. Then we dissect below the pancreas. And here is the normal pancreas, you can see. Then we divide the pancreatic tail from the retroperitoneal genital fascia fat. And this is stomach. So we always need to pull up the stomach to achieve adequate space to do the dissection. And some of the surgeon will cut directly of the pancreas during the surgery to achieve the blood supply and the venous system of the pancreas. For example, when we transect the pancreas, half of the pancreas will might encounter the splenic vein of the pancreas. And this is the smelly vein, which is one of the major vessels we always encounter during the distal pancreatectomy. We should do very careful dissection, because once you have injury of this major vessel, will cause a very massive blood loss during the operation. And we'll do dissection along the splenic vein. This is the energy device we usually use during the minimal invasive surgery. It's called harmonica. And you can heat and seal and transect the small vessel. So we can perform this without any suture or tie or clipping during our surgery. Okay, so this is the dissection along the splenic vein. So you can see this major vessel, and sometimes we'll dissect it, and then after we separate it from the pancreas, we can complete the transition of the pancreas. And then we can see after transition of pancreas, above the pancreas, we can see the splenic artery. Then we can resect the tumor along with the pancreas. In this case, this is not a pancreatic cancer case. We can do the preservation of the splenic artery and the splenic vein. And otherwise, we can directly transect the splenic artery and vein in this area. And this is the suture of the pancreatic transition site to avoid the pancreatic juice leakage from this transition site. So we already introduced the pancreatoduodenectomy and distal pancreatectomy. And now we are going to talk about the risk of the complication of this pancreatic surgery. Because this is a very complicated surgery. It's had a relatively high mortality and morbidity. According to the recent paper, even in the high volume center, the mortality of this procedure, especially pancreatoduodenectomy, can be up to 3%. And if you have the vascular resection, you even have a higher mortality, nearly 6%. And the morbidity, which is the surgical complication and the relative complication of this patient, it can achieve like 30% and nearly 40% in the vascular resection cases. So it's relatively high risk surgery, and I'll introduce why this surgery had easily to have those complications. As we just mentioned, this surgery had at least 3 anastomosis of the GI tract. So the anastomosis site might have some leakage, and this leakage might cause like intra-abdominal infection, and the reanastomosis of this GI tract and the major operation sometimes will cause a delay gastric empty, which means your food, after the surgery, when you take food or liquid, it will stay in your stomach longer, much longer than the other than the normal people and the other procedure do. Another big risk is bleeding. This bleeding might related to intraoperative bleeding and also post-operative pancreatic bleeding. And the major cause of this mortality and the original of the mortality are mostly related to the anosmotic leak and the bleeding condition. So we'll focus more on these two complications. This is the most popular way to do the pancreatic duodenectomy, which means the anosmosis between the pancreatic duct and the small bowel. This is the maybe the most difficult anosmosis in the general surgery area, because for first thing, this pancreatic duct is normally small. Most of the pancreatic duct, if there is no major obstruction of the pancreatic duct, is less than 0.5 centimeter. So it's very tiny and it's very difficult to have accurate anosmosis between the pancreatic duct and the small intestine. The other thing is the pancreas. Once the pancreas there is no inflammation or pancreatitis history before, normally the pancreas is very soft. You will like is like the some food like tofu. It's very very soft and easily to crush, or even when we do the suture, is usually to tear the pancreas parenchyma. So this is a very fragile and difficult to perform, difficult procedure to perform during pancreatoduodenectomy. There are two major ways to do the anastomosis. One is duct to mucosa anastomosis. One is invagination. The major difference is the duct to mucosa need to precisely anastomosis the pancreatic duct to the tiny hole of the small intestine to make the pancreatic duct to the small bowel mucosa healing together. And the invagination is the procedure to open the bigger side at the small bowel and try to put all the pancreas parenchyma into the intestine. And then you can decide to do the internal drain only, or you can also do the external drainage, external stand of the pancreatic duct. Statistically, the duct to mucosa procedure may related to less pancreatic leak, but normally the best anastomosis is the anastomosis that surgeon is more suitable and familiar, is the best anastomosis. And the pancreatic fistula is the major problem related to this surgery, and you should always check the amylase level from the ascites after the surgery on post-operative day 3. And there's a classification. If this amylase level is more than 3 times upper limit of your serum amylase value, it will be mentioned as a biochemical leakage, which was the grade A complication, grade A, the pancreatic fistula. We will also call it the biochemical leakage of the pancreatoduodenectomy. Then if this leakage persists more than 3 weeks, or you need some other procedure like a percutaneous drain, or the bleeding related to this pancreatic juice leakage, or the infection related to this pancreatic leakage, we'll call this pancreatic grade B pancreatic fistula, which means it will prolong the patient's hospital stay as well as the other procedure for the drainage or to do the hemostasis. And if this leakage persists and need another operation or cause the mortality or organ failure status, we'll call this grade C pancreatic fistula. So this is a major problem and major complication that every surgeon will face during the pancreatoduodenectomy, and we should always check the amylase level from the ascites, and always beware of the persistent drainage status, infection status, and the risk of the internal bleeding. The internal bleeding usually caused by the pancreas juice, the liquid pancreas juice erosion, the stump of the vessel we transect. So now we'll talk about the bleeding status. The bleeding status is not only happen post-operatively. We might face the major vessel bleeding during the operation, and we should be very careful and to calm down and to deal with this kind of complication during surgery. This is a video when we do when my teacher do the robotic pancreatoduodenectomy, and we have the SMB portal vein bleeding. You can see if you have the bleeding around this major vessel, you can cause a massive blood loss, maybe more than the 500 or 700 cc blood loss within a very short time period. So you try to control with your forceps, then use the suture or clip to slow down the blood loss to see the accurate hole of the vessel. Then you perform the suture ligation or the suture of the hole. Okay, so that's also the risk we might face during the operation. Another complication we might face is the post-pancreatectomy bleeding. This is another major complication and high related to patients' morbidity and mortality. In the 2019 large systemic review data, the incidence of post-pancreatectomy bleeding might up to 16%. And it's difficult to identify those sources. So even if you use the CT scan or diagnostic angiography, only less than 70% of the patient can detect these source of hemorrhage precisely. And the most frequent origin is the GDA. Why is GDA? Because as we just mentioned in our anatomy, GDA is the blood supply of the pancreas head area. So we usually or we always will transect the GDA during the pancreatoduodenectomy procedure. Once we have a pancreas leak postoperatively, the pancreas juice will erosion the stump of the GDA, which caused maybe the clip or the ligation side of the GDA erosion and bleeding again after surgery. The other common bleeding site is splenic artery and common hepatic artery. So these are also the some area we do the transection during the surgery. And once it had major bleeding, the overall mortality might be high as 21%. It's very high if you didn't deal with this postoperative pancreatic bleeding well. And with the primary intervention, angiography might be a better survival outcome compared to primary laparotomy. That's because it's the pancreas in the retroperitoneal area, and you already have a lot of anastomosis after this surgery. So if you want to re-explore this area, sometimes you cannot achieve the bleeding vessel easily. So currently the golden standard of the primary intervention might be the angiography and do the embolization of the bleeding area. And 2014, this journal provide a management protocol for based on their 1,000 pancreas resection experience. They divide two different post-pancreatectomy hemorrhage. One is intraluminal bleeding. The other one is extraluminal bleeding. Extraluminal bleeding mostly caused by the pancreas juice leakage. And if this pancreas juice leakage is or is extraluminal bleeding, it's happened within 24 hours after surgery. Normally, this is because of maybe the clip or the vessel did not secure well during surgery. So we can do explore LAPA within 24 hours after surgery, because after that we can achieve the bleeding site more easily without any adhesion, and we can do a hemostasis well. But if it's late hemorrhage after 24 hours, they suggest to do the interventional angiography to do embolization first, then go on if failure, then the last step is for laparotomy to do the hemostasis. Once it's intraluminal bleeding, if it's associated with pancreas juice leakage, you should always also go to the interventional angiography, then perform the operative hemostasis if failure. Once it's more than 10 days and there's no pancreas leakage, you should perform an interventional endoscopy, appendoscopy, to check if there's bleeding from the gastric ulcer or the small intestine or some anastomosis site. So this is the very complicated and protocol for post-pancreatectomy hemorrhage management, and we should always keep this in mind, because if you didn't deal with this complication well, it might cause a major complication and even mortality in your patient. And the next part will talk about the surgical progress in the pancreatic cancer. Before this, we talk a lot about the anatomy and what are those procedures we usually do in the pancreas surgery, and what kind of procedure we should do for the pancreas head cancer and the pancreas tail and pancreas body cancer. And in this year, there are some surgical progress in pancreas cancer, including the advance of vascular resection and reconstruction, and we start to perform more radical resection for the patient to achieve more clearance and more lymph node dissection, as well as the minimal invasive surgery, and it's developed in the past 10 to 20 years. Then now we have laparoscopic, we have robotic system, and how this new technology make the benefit to the patient. And then what is changing, and we start to have the multidisciplinary team treatment for the very difficult case of the pancreatic cancer. As we just mentioned before, when the pancreatic cancer is located in the head of the neck of the pancreas, we might face a problem of the vessel reconstruction, especially the SMV portal vein area, because this area, once you're transected, you will lose the major blood supply, major blood drainage from the intestine, and also we might lose one of the important blood supply to the liver. So this area, when we do the transition during the pancreas surgery, we should always have ability to do the reconstruction. And with vascular reconstruction technique, we can resect the longer area of this vessel, the portal SMV system. Then with this technique, we can achieve a better surgical margin, which means we can have better clearance of the pancreatic cancer, and with a better blood vessel control, we can have less blood loss during our complication. And with adequate knowledge and technique, this procedure will not increase the complication, mortality, and hospital stay. And there are several procedures we should perform, like if we want to sacrifice the splenic vein or not, or we can do the patch, or we can perform the side-to-side anastomosis with primary anastomosis or artificial graft. And this procedure, this is a video of the venous reconstruction, and we will see how they do the blood vessel control and how they do the anastomosis. So firstly, you need to divide the SMV, and this is the splenic vein, and also the portal vein, to control this area. Oh, 3 major vessel sites. Then you cut down the pancreas with the tumor without cutting the tumor. And we start to count because once this anastomosis is longer than 20 minutes, then the bowel will start to have congestion and edema. So this is a case my teacher performed the anastomosis, end-to-end anastomosis directly between this is portal vein and this is SMV, and this is splenic vein. So we perform a direct anastomosis with a robotic system. So with adequate dissection, we can have very well blood control by this bulldog clamp. So we won't have the bleeding during our anastomosis. And we let go the bulldog vascular clamp. We can see this anastomosis, very beautiful anastomosis for this area between portal vein, SMV, and splenic vein. And about the arterial resection and reconstruction, this is the paper I submit last year. We do we can use some variant of the artery the hepatic artery. For example, this case is a case that the hepatic artery system is totally replaced from the SMA system, because the normal common anatomy is the common hepatic artery will come from the celiac trunk, but in this case, you can see the common hepatic artery comes from the SMA. So once the tumor invasion this part, we can resect it without SMA reconstruction and celiac trunk reconstruction. We only need to reconstruct the hepatic artery, so it will become more easier for the surgeon and will cause a survival benefit to the patient. Another surgical progress I want to introduce is the concept of the mesopancreas excision. Mesopancreas is a concept that we discovered in these years. We found that the surgeons found that there's a mesopancreas triangle between the SMV and the SMA and the aorta. In this area is very deep of the pancreas, and sometimes when we transect the superficial part and Usina process area in the traditional way, we sometimes will leave some metastatic soft tissue and metastatic lymph node in this area. We did not clean this part very clearly. But if we do this, the pancreatic cancer will normally recurrent from this area and cause further distal metastasis. So surgeons start to re-evaluate of the surgical anatomy, and the surgeons start to find that this area might be cleaned together with the pancreatoduodenectomy procedure. So in the Annals of Surgery, one of our best journal, they have published this concept. When you face the invasive pancreatic ductal cancer, you should do at least level 2 or level 3 mesopancreas excision. What is the different level of the pancreatic mesopancreas excision? The level 1 means the traditional procedure of the pancreatoduodenectomy procedure. We only clean the right side of the SMV only. But if you do the level 2 or level 3, you need to do the dissection along the SMA. And even in level 3, you need to clean the adventitia of the SMA from this the right side of the SMA. So you will clean also this area, the soft tissue and neurovascular bundle, and all the lymph node from this area. And this is the detail of level 2 mesopancreas excision. So you can see you do the dissection left side to the SMV. We separate the SMV and SMA, but we keep the soft tissue and the adventitia of the SMA. But in the level 3 mesopancreas dissection, you need to peel off the SMA from the neurovascular bundle and the adventitia from 11 o'clock to 5 o'clock. So we can have completely clearance of this neurovascular bundle and the lymph node, which might cause the recurrence of the tumor in this area. And what is the benefit of this procedure? This mesopancreas excision, we achieve artery first and dissect along the artery, we may cause the shorter operative time, less blood loss, and lower post-operative pancreas leakage rate and delayed gantry rate. And it did not cause increasing of the complication and hospital stay. And this is the video provided by the Annals of Surgery. I think it's an Italian center. And as we mentioned before, this procedure usually need to do the venous resection and reconstruction. So this procedure will do along with the SMA. So you can see this is the SMA, and this is the SMV. So traditionally, traditional pancreatoduodenectomy will do the resection right side to the SMV. But in this case, we start to perform mesopancreatic excision. So we'll do the resection along the SMA. So with this video, you can see the position. This position is SMA. So we make a very clearance of the SMA. So this part of the soft tissue, that's we call mesopancreas. And once the tumor or cancer cell or lymph node around this area will be resect together with the whole tumor. So you will reduce the recurrence and reduce the rate will transect those metastatic area. Another thing is when we do very clearance of this meso, we do surgery and dissection along this vessel, we can do the blood vessel control at the very base of like very base of this blood vessel, which supply IPDA is the inferior pancreatoduodenal artery. So we can secure the blood vessel here. So when we do the other dissection along the pancreas, we will have less blood loss during operation. As a result, this is a very important procedure in the pancreatic cancer surgery. It will cause less blood loss and more clearance of the pancreatic cancer. Okay, so because this is a very long video, so I just want to show you the SMA dissection that we call typical the mesopancreatic excision. And what is the progress of the distal pancreatectomy? A new procedure called the RAMPS. The name is radical antegrade modular pancreatal splenectomy. It's a new fashion to do a right side to left side antegrade approach. And besides do the pancreas resection and the spleen resection only, this procedure will emphasize the right side to left side antegrade fashion, and also to remove all the genital fascia, which means the retroperitoneal fascia and fat, and even the adrenal gland of the left side adrenal. So why we need to do this procedure? Because in the pancreas cancer, sometimes the lymph node will hide in this fat, and sometimes the pancreatic tumor or pancreatic cancer cell will stay in this soft tissue area. So if we take transitioning the black line dissection only, sometimes we'll miss some pancreas remained cancer cell around this area. And if we perform IMP, we can remove very clearly and do this dissection along the vessel and kidney. So this area will be clean with a better clearance. And this is a systemic review of the IMP procedure. We can find that the better negative margin, which is better clearance, a better lymph node harvest. And long-term survival in this systemic review is similar, but we believe that once we follow for a longer time, the better survival can be observed. Another new and procedure of pancreatization, we call it CAR procedure. What is CAR procedure? Is a celiac axis resection. As we mentioned before, the tumor in the body or the neck area might cause the invasion of the celiac trunk. So if we want to resect the celiac trunk, we might have a problem of the blood supply of liver, because celiac trunk, normally the common hepatic artery is come from the celiac trunk. So we're wondering, initially the surgeon were wondering that what if okay. Okay. Once we have the tumor invasion in this area, the surgeon wondering, what if we resect the celiac trunk? The blood, where is the blood supply of the liver come from? Then we found that once the GDA or the SMA is once the SMA and GDA is okay, then is pattern, then we can preserve the blood supply from SMA to IPDA, then to GDA, then supply the liver. So then by this concept, we start to have a very radical procedure to resect the celiac trunk like this. Or if we have the variation, we can resect the celiac trunk with the reconstruction of the artery. So by this procedure, we can resect the advanced pancreatic tumor more precisely and make the long-term survival of the patient better. 我怎么下一页？改这个，这个下一页。不是，没办法按下一页。这个，好，取消。哦 ，OK。Then I will talk about the minimal invasive of the pancreatoduodenectomy because this is the new procedure, minimal invasive procedure like a laparoscopic approach or robotic approach. And as we just mentioned, this surgery is already one of the most difficult surgery in HPV area. So if we want to proceed this surgery to a minimal invasive area, it will become a more difficult. So some surgeon will say this is the peak of the mountain Everest in the modern surgery, which means the minimal invasive pancreatoduodenectomy. And what is the challenge in pancreatic cancer? Because if you have a benign lesion or ampulovalvular cancer, it's much easier to do a dissection. But if you have the pancreatic cancer, you might face some challenge like no preoperative tissue proof. You cannot make sure the diagnosis, or this patient has received chemotherapy or radiotherapy, or you need to encounter the vascular resection and reconstruction. So the development of a minimally invasive procedure, we normally start from the hybrid method, which means we can try the resection with the minimal invasive, then we do the reconstruction as a traditional way. Then we start to have a laparoscopic procedure, following by robotic procedure. Then the most difficult part might be the minimally invasive artery or vein reconstruction. And this is the video of the robotic pancreatoduodenectomy. I just want you to have a very short concept of how this all procedure performed. This is the robotic arm. So this robotic arm has the wrist, so it can perform the procedure like the human's hand. With energy device, we can dissect those soft tissue part. This is called a Cocker maneuver. We pull out the duodenal area and separate them from the colon. Then we transect the small bowel with the auto suture. Then we do the venous dissection. We can see below the pancreas, you can see the major vessel SMV. This is SMV. And then we can transect the pancreatic neck with this harmonica scalpel. It's an energy device. And you can see the common hepatic artery and GDA. So GDA is usually transection during the pancreatoduodenectomy, and we should always be careful of this procedure because it's also the most common part of the post-pancreatectomy bleeding. Then this will cut through the CBD, common bile duct. This is a common bile duct. And then we'll transect the stomach with this is auto suture. And finally, we'll take the Usina process of pancreas. This is Usina process of pancreas from the SMV. And this is SMV and portal vein. Then we have some stump of the vessel. We need to suture it. So with robotic system, now our procedure can perform this surgery with minimally invasive technique. So the patient only have a very small wound of their abdomen instead of traditional wound. Traditional wound, maybe you will have a large incision more than 20 centimeter, but with robotic or laparoscope procedure, you can only have 5 or 4 small wound. Each one is less than 2 centimeter. So the patient will not suffer from the postoperative pain or can have early ambulation. This is an osmosis duct to mucosa procedure of the pancreas and to the jejunum. Another benefit of this procedure by robotic or laparoscopic is with intra-abdominal camera, we can see this tiny hole very clearly because it's 10 times larger when we see from the robotic or laparoscopic camera. So when we do the anastomosis, we can do more precisely than we see from our eyes. So this part we complete the anastomosis. Then we will have the hepatical jejunal anastomosis and the gastrojejunal anastomosis. So benefit of minimal invasive PD, pancreatoduodenectomy, will cause less wound pain, less allergic injection use, shorter postoperative hospital stay, and less blood loss and more harvest of the lymph node. And the safety and clinical outcome of the minimal invasive surgery is, according to the systemic review, it's as safe as the open surgery before. And for the cancer case, we will focus on is this surgery have a similar oncology outcome, is minimal invasive, is safe and can provide the same survival as the traditional surgery, is what most surgeons concern. And recent systemic review also showed that the minimal invasive can achieve the same survival and the resection rate as the open surgery. So in our center, we start to use this minimal invasive surgery especially to the elderly patient. Our concept is that with the elderly patient will have relatively high mortality and complication. So if they did not recovering very well and quick after the surgery, they'll have less chance of the chemotherapy. So this is our publication. We found that in our center, the elderly patient more than 65 years old, they receive minimal invasive surgery. They might have, even if they have the worst performance before the surgery, some of them, 20% of them are ECOG 1, and even 2 of them are ECOG 2. These patients have same postoperative recovery rate compared to open group, and the hospital stay is shorter, drain removal day is shorter, and the delayed gastric empty status is also less than the open surgery, which means even if the patient have the poor ECOG status, poor performance status, you receive pancreatoduodenectomy with a minimal invasive. In our hospital, you can have shorter hospital stay, less delayed gastric empty, and earlier drain removal. And the last part, I will show some cases. We perform this surgery with the cooperate between different department of doctor, including the surgeon, radiologist, and oncologist, and pathologist, and ICU care. This is called the multidiscipline team treatment. And now we always suggest you have pancreatic cancer patient, you should refer to a multidiscipline team. And why we need a multidiscipline team? Because now many of patients, they need neoadjuvant chemotherapy to have better survival. And if the best pancreatic cancer treatment now will be neoadjuvant first, then radical surgery, then followed by adjuvant therapy. especially for locally advanced borderline resectable cancer and highly selective resectable cancer. And this is a case of I operate for the 69-year-old male. He has a Usina process, large tumor with vessel invasion. Also, the lung metastasis is the terminal case, is a stage 4 pancreatic cancer. But this case received neoadjuvant chemotherapy first, then the tumor shrinkage a little bit, and the lung cancer had improved a little bit. So we decided to do the procedure for the patient. So preoperative, we combine then oncology and radiologist to re-evaluate the image and to do the neoadjuvant chemotherapy. And our surgeon will provide the Whipple procedure with level 3 mesopancreas excision, as you see the SMV and SMA, and the reconstruction of the major vessel. Then we combine with the pathology to make sure all the clearance of the surgery. This is another case of a 59-year-old female. She had two cancer. One is high-grade serous ovarian carcinoma, and also the pancreatic cancer. After 4 cycles of neoadjuvant chemotherapy, we decide to perform the operation for her pancreatic cancer. You can see this pancreatic cancer also invasion the O vessel around the neck area, including SMV, splenic vein, and portal vein. So in this case, we also perform level 3 mesopancreas excision, and we perform the en-bloc total pancreatectomy, which means together with the spleen, pancreas tail, and pancreas head together, and the mesopancreas excision, also the pancreas, the portal vein and SMV reconstruction. The final case I want to share is a 64-year-old female. This is a pancreatic neck and body pancreatic cancer with celiac trunk invasion. And we combine with the oncologist to do the neoadjuvant chemotherapy first. Then we do the preoperative celiac trunk embolization, which means we embolize the celiac trunk to make sure and all the blood supply will come from SMV and supply the liver from the GDA. And our surgeon will perform the surgical resection. This is the whole celiac trunk and the hepatic artery. We can see the embolized coil inside the vessel. So we perform the RAMP, radical antegrade pancreatoduodenectomy, with CAR, the celiac axis resection for the patient. And the patient, this is combined the oncologist, radiologist, and surgeon to cooperate together to treat this difficult disease. And to achieve this very difficult procedure, you need to have a very strong pancreatic cancer team, and you always need to visit the other high volume center to learn how to perform better surgery, and you need to achieve the international conference, the Asian conference, Asian Pacific conference, and the international conference to publish your research and had interaction and to other top surgeons in the world. Okay, so this is my last slide. Just want everyone to have some idea of the treatment and diagnosis of the pancreatic cancer. So always need to have the early diagnosis and tissue proof as possible as you can, and you need to have a very well preparation of the surgery and do the radical surgery and clearance of the cancer as much as possible, and then you need to have a multidisciplinary team treatment for the patient. So if you have those difficult pancreatic cancer, please refer these patients to high volume center to achieve these three very important the detail of treatment. And that's all my talking today, and thank you for your attention. Okay, is there any question for this lecture? So that's all my lecture today, and thank you for your attention.
Thank you, Dr. Shi.